Muito bom dia a todos e a todas. Estamos ao vivo em mais uma reunião geral do Departamento de Psiquiatria da Faculdade de Medicina da Universidade de São Paulo. Com grande alegria que retomamos aí as atividades, retomamos as pausas de final de ano. Esperamos aí que todo mundo tenha tido um final de ano fantástico com as suas famílias. Bom, hoje temos a honra e o prazer de termos uma convidada internacional, que é sempre algo muito importante para todos nós, que vai contribuir com o tema Adolescent Mental Health and Neurodevelopment Across Diagnostic Categories. E quem vai apresentar é a professora Giorgia Michelini. Ela é professora em psicologia na Queen Mary University of London, no Reino Unido, e pesquisadora assistente e visitante na Universidade da Califórnia, em Los Angeles, UCLA. É vencedora do prêmio NARSET Young Investigator e tem uma bolsa Klingenstein, da Third Generation Foundation em TDAH. Para comentar, uma conhecida nossa, a professora doutora Elizabeth Shepard, que possui graduação em Psicologia e mestrado em Neurociência Cognitiva Social pela Universidade de Aberdeen, na Escócia, doutorado em Psiquiatria da Universidade de Nottingham, Inglaterra, trabalhou como pesquisadora de pós-doutorado no Institute of Psychiatry, Psychology and Neuroscience, do King's College London, e atualmente é uma jovem pesquisadora de neurociência cognitiva no Departamento de Psiquiatria em conjunto com a FAPESP. So, it's a great pleasure to receive you here, Giorgia, for our department. I'm sure we will be very glad to hear your talk today. So please, go ahead.
Obrigada, thank you very much. That's like the one word in Portuguese that I know, so I've used it already. So here are my slides. Do you still see them well? It's loading. Yes?
Yeah, we can see.
Perfect. Okay. Thank you very much to Lizzie and everyone for the invitation to share some of our work in your grand round today, and it's a wonderful opportunity, and I'm really looking forward to discussing with you later about some of this work and its implication, and maybe thinking of some collaborations in the future. So as Rodolfo was saying, today I will be talking about adolescent mental health and neurodevelopment, the disorders that affect mental health and neurodevelopment, and how we can think about these conditions across diagnostic boundaries. I'll start broadly discussing the impact of mental health and neurodevelopmental disorders, especially young people, which is the population that I mainly focus on. Then I will talk about transdiagnostic research approaches that encourage us to think about these conditions across different disorders categories and moving away from traditional boundaries. These are the research domain criteria and the hierarchical taxonomy of psychopathology. And here I will discuss a few studies that I have been working on that are inspired by these frameworks. Then I will move to thinking about how RDoC and HiTOP approaches could be integrated and building on their respective strengths to potentially advance the field even further. And then finally, I will wrap up with some take-home messages and where I think we should be heading next in this field. So it's not going to be any surprise for any of you that mental health and neurodevelopmental problems are extremely prevalent, and especially within adolescents and young adults. This is really severe problems, which has become even more apparent during the pandemic. But even before the pandemic, we have known that mental health problems tend to emerge in early in development. So about half of the people that start developing mental health conditions start before adolescence, and then 2/3 by early adulthood. An important aspect to consider is that the earlier these disorders emerge, the greater the impact they have. So we know that these psychiatric and neurodevelopmental conditions starting early in development can lead to lifelong, very severe impact across all areas of life, basically. The most common conditions that affect youth mental health are ADHD and mood and anxiety disorders. These disorders are very often also presenting in comorbidity, and the co-occurrence between anxiety and mood disorder is very well researched and very often talked about. But I would also like to emphasize the co-occurrence between ADHD and mood and anxiety disorders, in that people with ADHD have a much higher risk of developing subsequent mood and anxiety disorders compared to neurotypical youth. And this comorbidity can lead to even worse outcomes than any of these conditions alone. And despite the increasing awareness of mental health difficulties within in youth, there is really quite a long lag between when these problems start emerging and when youth start receiving any sort of treatment. This has been estimated to be about 10 years to the point that treatment is actually provided to these youth. And if we think about this would be completely unimaginable in other fields of medicine. If we think about the great progress that has been made in prevention and screening of some forms of physical health, such as some forms of cancer, for example. So we are really lagging behind in this idea of trying to catch these disorders early and intervening early when it comes to mental health problems. But why do we think that adolescence in particular and development are a period of particularly high risk for the development of these conditions? Well, research seems to suggest that a possible reason is that there is an imbalance in the brain maturation of different areas of the brain during adolescence. So we see that there is a stronger, faster development of areas that are subcortical and that are involved in emotion, risk-taking, and reward processing, whereas areas that are more frontal in the brain tend to maturate more slowly. So this creates an imbalance between these areas that are called the accelerator of the brain and areas that are called the brains, the brakes of the brain, using car analogy, in a way that adolescents may be more prone to developing disorders, especially during this developmental period. And we can also think about how mental health and neurodevelopmental problems evolve during time by considering the interplay between genetic and environmental and psychosocial risk factors, and when they tend to have an influence over the course of development. So this very nice graphic from one of Anita Tappar's work essentially shows how different genetic and environmental risk factors may have an impact, and how this is related to the emergence of different mental health problems over the course of development. Of course, neurodevelopmental problems starts earlier, and then we have anxiety, mood disorders, and finally psychotic disorders. But one thing to consider is that these disorders are rarely just emerging in isolation. Rather, they most often come about in people that have had previous difficulties, such that earlier neurodevelopmental problems may be a risk factor for developing later psychiatric conditions. And a recent study perfectly showed us this using the Dunedin study. This is a very famous birth cohort of over 1,000 people in New Zealand who were followed up over 4 decades. In this graph, we can see that those that had an earlier onset of any condition are then showing a greater risk to develop several other mental health disorders over the course of 4 decades, with the last follow-up being at age 45. Compared to those that had a later onset of any of these, any psychiatric condition, who then still had the risk of developing comorbidities, but much reduced compared to those that had an earlier onset. And another beautiful graph from this paper on the Dunedin cohort is showing us the proportion of people within the cohort that shift diagnosis from one time point to the other. So this shows how much shift there is really from one group of conditions to the other. Some within the externalizing type of disorders continue having an externalizing disorder, but many others shift to having internalizing, or having both internalizing and externalizing, or also having a more psychotic disorder. And this shifts continue happening over the course of the development and into adulthood. This pattern is then even more pronounced if we consider the minority of the sample that have received an inpatient mental health services, about 8%, 8%, so about 80 people within the cohort. You see here the shift between disorders categories is even more pronounced. This striking data, I believe, perfectly shows us not just that longitudinal cohorts are so important for understanding mental health, but also perhaps that all this shifting between diagnostic categories might actually be a product of the binary nature of psychiatric disorders and of the current categorical classifications like DSM and ICD. The categorical systems very much emphasize on individual diagnosis, so the majority of research in psychiatric disorders actually focuses on one disorder at the time, rather than capturing this complexity of several different disorders emerging within one individual. And as a consequence, our approaches to treating these conditions are also very much focused on specific treatment pathways that mainly address what is believed to be the main diagnosis, and do not quite know how to address the co-occurring disorders. At least this is how mental health services work here in the UK. This seems to be quite contrasting with what research shows about psychopathology and neurodevelopmental disorders, because we know that there is really a continuum between health and non-health when it comes to mental health. So symptoms of psychopathology are distributed continuously in the population, and there is also a lot of variability in the way these symptoms present within the same person over the course of development, but also in the way that the same condition might be manifesting across different people with the same diagnostic category. And there is also a lot of evidence from neurobiological and genetic research showing that the risk factors for different diagnoses are really cutting across different categories. A striking example comes from work in genetics, where it has been shown both by twin studies, but also more recently in genome-wide studies, that approximately half of the genes that increase risk for one disorder may also increase risk for other disorders, with some variability across different conditions. But for example, between bipolar disorder and schizophrenia, there is an overlap in 70% of the genes influencing one and the other. For ADHD and major depression, it's 44%. So even disorders that might not be classically considered to belong to the same kind of diagnostic group, like ADHD and mood disorder, they tend to actually have very strong link at the genetic level. So in response of some of these limitations of categorical diagnosis, the field has started moving towards emphasizing more transdiagnostic approaches, which means that emphasizing research that moves away from this categorical classification of mental health and rather wants to look at dimensional constructs that may be common across different diagnoses. The advantages of these transdiagnostic approaches is that they take into account this evidence that psychopathology do exist on a continuum, and it manifests more as a dimension rather than a category. They also have a better way to account for subthreshold presentations, where when you see somebody who is just short of meeting criteria for a certain diagnosis, it's not it's not easy to know what we can advise, whether they can be treated. And instead, if we think about a more dimensional way of considering these symptoms, this could have some advantages. And what I'm gonna focus on today are two main transdiagnostic frameworks that have been developed over the last 10-12 years, which are the research domain criteria and the hierarchical taxonomy of psychopathology. I will start with RDoC and show some research that has used this framework from our work. So RDoC was developed in the US by the National Institute of Mental Health with the idea that there was a need for a framework that would be able to inform research on the neurobiological basis of psychopathology and potentially help developing better biomarkers, and then ultimately to use this knowledge about the understanding and etiology of mental health to guide future psychiatric classifications. The framework is very much grounded in neuroscience in the sense that it emphasizes research that really focuses on brain circuits and different levels of analysis within that are informed by neuroscience. And it includes several dimensional constructs that are defined as biobehavioral in the sense that they can be characterized across different units of analysis. Again, mostly focusing on levels that can be investigated through neuroscience research, but also with some additional units that are more behavioral, like behavioral paradigms and self-report measures. The way that RDoC tends to recommend doing research is to move away from the classic case control type of study and consider more what they call transdiagnostic sampling, which means using clinical populations that include several patients of several different conditions in order to be able to characterize each individual based on different biobehavioral dimensions and how different groups might be delineated within this broader clinical population. I'll give you an overview of some of the work we have done that is partly consistent with the principles of RDoC, and particularly focusing on the idea of identifying biomarkers of ADHD and co-occurring conditions. So we all know that ADHD is very often comorbid with other psychiatric disorders, but why should we really care about identifying biomarkers for these additional comorbidities? Well, a main reason has to do with wanting to understand the mechanisms underlying ADHD and these other disorders. So if we don't consider explicitly the co-occurrence of different types of symptoms within ADHD, it is difficult to tell whether a possible mechanism that we are investigating is specific to ADHD, or rather is the product of the co-occurrence between different conditions within the same individual, meaning that this would be considered a transdiagnostic mechanism rather than something that is specific to ADHD. And this is not just with the view of understanding mechanisms, but also to really be able to inform possible development of new treatments and identifications of biomarkers for ADHD and other co-occurring conditions. So it really moves from being interested in mechanisms, but also how we can use this knowledge of mechanisms to inform clinical practice. The reason for wanting to look at ADHD and mood disorders are clear based on epidemiological findings showing that there is a very strong overlap, but also that ADHD, the emergence of mood disorders in ADHD tends to be associated with much worse outcomes. And there is also quite a lot of interesting research that focuses on the overlap between different symptoms of ADHD and mood disorders in the areas especially of attention problems, motivation, difficulties, and mood or emotional lability and irritability. What we are starting to think is that these possible similarities in clinical manifestations might be, to some extent, explained by some shared mechanisms of the different groups of conditions. So, for example, executive functioning difficulties have been studied extensively in ADHD and also separately in mood disorders, and similarly, emotion regulation difficulties are associated with both ADHD and mood disorder, and reward sensitivity in the same way. Some of our work has started to focus a bit more on these shared processes, and in particular on attentional processes within executive functioning, which we are characterized from behavioral units of analysis, as well as using measures from paradigms where we can get measures of cognitive performance, and then finally using EEG data to have get some insights about the brain mechanisms underlying these different processes, with an idea that EEG also carries practical advantages that may in the future bring these discoveries to be able to inform clinical and translational applications. I'll present some findings from a study where we had individuals with ADHD compared to individuals with bipolar disorder and neurotypical controls. Just very briefly looking at the symptom level and scales of psychopathology, it was quite interesting to see that the two clinical groups were really only differentiated by measures of ADHD. So the ADHD group had much stronger ADHD symptoms compared to the bipolar group, but this wasn't the case when we were looking at scales of mood disorders. So the two participants with ADHD and with bipolar disorder during euthymia really had similar levels of depression, as well as manic symptoms at the time that we were seeing them. And then our main aim of this study was to look at possible EEG and cognitive measures that would distinguish between these two groups, thinking at the time that we could potentially find some biomarkers that could aid in the distinction between these two conditions. But really, to our surprise at the time, we found a lot more sharing than we thought. So in particular, I'm showing here 2 Eeg markers that were measured during response inhibition and attentional paradigms. This is an EEG measure of response inhibition, and this is a measure of response preparation during an attentional task. What you can see here is that both the ADHD and bipolar disorder group show a reduction in EEG activity across both of these event-related potentials, which suggests that response inhibition and response preparation might be shared, maybe similarly impacted by ADHD and bipolar disorder. And then in a more recent study, we also found this interesting additional finding for this measure that basically is an indicator of neural consistency. So it indicates that there is the variability at the level of brain processing of a stimulus over the course of a task is much greater in individuals with ADHD and in those with bipolar disorder compared to controls, without any significant difference between the two clinical groups. And quite interestingly, this also matches with the results that we had at the cognitive level, where we measured reaction time variability. So the ADHD participants and those with bipolar disorder both showed greater variability in their reaction times during this task compared to those without either of these conditions. And quite interestingly, this latter pattern of findings of inter-individual variability at the cognitive and neural level also fits with models that emphasize on the role of mind wandering and rumination, perhaps racing thoughts within ADHD and mood disorders. So we more recently started thinking about this in the context of ADHD, where we proposed with colleagues at King's College London, we proposed a model of emphasizing on how mind wandering may be a core component of ADHD, where that would basically explain the increased level of inattention as well as the increased inter-individual variability in reaction times. And also more recently, we found some initial support for this hypothesis within a sample of adults with ADHD and controls, where we found, not surprisingly, that mind wandering was related to inter-individual variability in reaction time, and also with the same measure of neural variability that I've shown you in the previous slide. So again, linking all these aspects together and emphasizing on the possible role of mind wandering in ADHD. But considering that mind wandering may be quite similar also to what is called racing thoughts in bipolar disorder and rumination within studies of depression, we really need future studies that will try to map these different processes and how attentional and difficulties and different patterns of thinking may be shared between all these different conditions. Another set of findings that I'm going to present is based on a large study of children and adolescents with and without ADHD that we conducted at UCLA. This was a very large sample that was very well characterized also on other symptoms of other disorders, especially with a focus on depression in this study. And we were interested in looking at what how different processes related to attention and working memory may be associated with ADHD symptoms and depressive symptoms. We used this task that is a spatial working memory task, where we are essentially able to separate a phase of the task where participants are only viewing a number of dots that they are told to need to remember. So this early phase is basically a stimulus processing phase that probes attention processes. And then we have separately an interval where the participant needs to retain in their memory the positions of the dots. And then finally, they need to tell whether a new probe is mapping onto working memory processes. And here we investigated a number of Eeg markers in relation to ADHD and depressive symptoms from parent reports from the CBCL. We're looking at measure of EEG power that is event related to this task stimuli. This is what we can represent with these colorful graphs, where essentially any changes in color from 0, which is no difference in color, is basically reflecting a change in power from a period before the onset of the stimulus. So what we are seeing here is that there is a decrease in power time locked to the stimulus presented during the task. And this activity is mainly localized at the level of the visual cortex, as we would imagine. So it's associated with visual attention. And what we are seeing is that there is an association between this activity in the alpha band and both ADHD and depressive symptoms, so that higher levels of ADHD and depression are associated with a reduction of power in this area. And quite interestingly, though, when we run models that tend to account for the co-occurrence between ADHD and depression, so essentially some partial correlations, we see that the association with ADHD symptoms remains even when we are controlling for depression, but not the other way around. So the association with depressive symptoms is partly explained by the correlation with ADHD symptoms. And then in another set of analysis, we were interested in patterns of connectivity between different regions of the brain during this task. So looking at the brain functional connectivity from occipital regions to frontal regions and several other regions that are involved, that are evoked during these spatial working memory tasks and implicated in attentional and working memory processes. This is just a representation of our analytic approach. This was developed by Professor Sandra Liu's lab at UCLA in collaboration with colleagues at UCSD. So you can read more about this method if you're interested. But basically what we were interested in looking at here was whether patterns of connectivity would be able to discriminate people with ADHD and controls, and whether continuous levels of ADHD and depressive symptoms would be showing similar or different associations with functional connectivity. Looking at connectivity during the stimulus encoding phase, so anything that would be related to visual attention, essentially, we did find this very interesting finding where participants with ADHD tended to have increased connectivity from frontal regions to medial occipital regions, so which we can probably interpret as a pattern of frontal, parietal, and occipital connectivity that is associated with the executive control network. Not only this difference was significant between those with ADHD and controls, but it was also continuously associated with symptoms, severity of ADHD symptoms. This correlation was, however, specific to ADHD and not to depression. So there wasn't any association with depressive symptoms here. We found very much the same pattern of results also across the maintenance phase of the task, so associated with working memory storage. And then finally, during the retrieval phase of the task, so when participants need to use their working memory processes to respond to this, whether the new dot is matching the previous location, so working memory recall. But then another interesting finding that also emerged within this retrieval phase was that there were differences between those with ADHD and controls in connectivity from occipital to temporal regions, so which have been implicated in connectivity during working memory processes, and especially in relation to processes related to audio visual recognition. So it all makes very much sense with what participants were doing during this task. And additionally, we did find that these two measures of connectivity were associated both with ADHD severity as well as with depression severities. When we then went to look at whether these two different symptom dimensions were partly were jointly contributing to these patterns of findings, we found that there was still a quite strong association with ADHD symptoms when we were controlling for depression, but the other way around, there was still some indication of association with depression when controlling for ADHD, although this was more attenuated. So potentially indicating that the association between depressive symptoms and patterns of occipital temporal connectivity is partly explained by symptoms of ADHD within this sample. So to summarize briefly some of these findings, we have some evidence that there are some EEG profiles that are associated to both ADHD and depressive symptoms using both measures of alpha power during this working memory task, as well as of functional connectivity. With, however, also some indication that some of these overlapping associations may be explained by the co-occurrence between ADHD and depression. And one thing to note is that this study was still based on a cross-sectional sample, so it will be very important in the future to extend this work to longitudinal samples, and also to expand our investigation to other processes that are associated to both ADHD and depression, such as, for example, emotional and reward processes. I will now turn to some other recent work that is more consistent with the HITOP initiative. So the hierarchical taxonomy of psychopathology was developed by a consortium of mental health researchers and clinicians that were mainly based in the US when the framework was launched about 5-6 years ago. It's basically informed by several years of research on factor analytic methods that have shown that there is a consistent structure of psychopathology across different factors, across different studies, sorry. So the one very clear thing at first that we can take from about HITOP is that it's very much focused on clinical features of psychopathology. The other key aspect is that it emphasizes dimensional constructs of symptoms and syndromes and maladaptive traits because of the evidence that these dimensional constructs are more reliable compared to diagnostic categories. And the organization of HITOP is one that is based on a hierarchy, considering that it goes from broader general dimensions and then goes down to narrower and narrower dimensions, getting to characterizing individual symptoms and components. The model seems to be so far basically reorganizing different symptoms of different DSM diagnosis. So this figure here shows broadly how the DSM diagnosis would map onto different constructs from HITEP, where, for example, different in what are called like forms of internalizing psychopathology can then be split down into different sub-factors, and these sub-factors quite well map onto different categorical diagnoses within the DSM that go from mood disorders to anxiety disorders and eating disorders, for example. So the main premise of HITEP is that psychopathological symptoms may be represented as a hierarchy, and the basic sort of structure of it can be shown here with lots of research that has shown that it's possible to derive an internalizing factor or an externalizing factor or a thought disorder factor that will load onto different symptoms of specific diagnosis. But the additional component here is then also with the addition of a P factor. This is what has recently been introduced by a few studies that consider that the covariation between different dimensions of psychopathology may be explained by this general factor of psychopathology, or the P factor, which explains the psychiatric comorbidity and may represent a shared level of risk across different forms of disorders, with the idea behind it being quite simply that the risk having a disorder increases risk for having any other disorder, and that many of the treatments for mental health processes, mental health disorders, tend to be transdiagnostic in the sense that, for example, SSRI can be used for treatments of different types of conditions. And Avshalom Caspi and Tammy Moffitt are among the researchers that introduced the P factor. And in the recent study that I introduced to you earlier during this talk, they also looked at how the P factor maps onto different diagnoses within their Adhd study. So looking at a sort of cumulative measure of the P factor over the course of the study and the number of these diagnoses that these participants were meeting over time, they found that higher levels of the P factors correspond to meeting a greater number of conditions during these 4 decades. So again, emphasizing on the explanation of what this P factor actually might represent. Turning to some of our work, we were interested in looking at how dimensions of psychopathology consistent with the HITEP model may be characterizing adolescent and child's mental health. The reason for this is that much of the research that fed into the HITEP model was conducted in adult populations. So we still actually know quite little about how these factors can characterize younger populations. And what we were interested in seeing was to look at this broader dimension, but also to investigate some of the putative underpinning that might be underlying several different conditions, as well as how these different dimensions may be associated with a number of functional outcomes, with the rationale of wanting to get this information to be able to inform assessment and classification of psychopathology in adolescents, but also to be able to identify some of the shared outcomes and risk factors that could be characterizing psychopathology more broadly in this age period. We conducted this study using a very large sample of teenagers in the US. This is the Adolescent Brain and Cognitive Development Study, where essentially using simple symptoms of the CBCL, we mapped a hierarchy consistent with the Heighton model, going from a P factor to internalizing and externalizing broader dimension, and then narrowing down to 5 specific factors: internalizing, withdrawn, somatic, neurodevelopmental problems, and externalizing problems. And we then were keen to understand how these different factor structures that are very much coexisting within one another were related to associations with clinically relevant outcomes. So what I'm showing here, for example, is that a model that just included the first factor, so just the P factor, was able to explain a lot of the variance in whether a participant had or had not received mental health services. So when we were then considering models that were more complex and were including up to 5 factors, the increase in explained variance was actually quite small, indicating that the P factor alone might actually be sufficient for wanting to understand these more broad mental health outcomes. Conversely, when we wanted to look at association with academic achievement, the P factor alone only explained about half of the total variance that could be explained by these dimensional models, with an increase in variance explained in this school grades outcome with a greater number of factors that were putting in. And quite interestingly, this also is associated with the delineation of these neurodevelopmental factor, withdrawal factor, which are very much associated with outcomes within school settings. So again, suggesting that while the P factor alone might not, while be good at capturing broader outcomes related to mental health, we might want a greater granularity with a greater number of narrower dimensions when we want to study other types of outcomes. Another example that I'm going to show you is from this other study where we wanted to investigate these dimensions of psychopathology at an even younger age. So we were able to assemble this large sample of over 1,000 children that were seen during when they were in early childhood between 3 and 6 years. We modeled a psychopathology structure consistent with HITEP, and then we looked at how these early factors were predictive of outcomes in pre-adolescence, where all these participants were followed up over a decade. This is a structure that we delineated through factor analysis, so similarly to the one that I've just shown you, with the P factor at the top and then going down into specific dimensions. The specific dimensions are slightly different from those that I've shown you through the CBCL, and this is just probably partly because of the different measure that we use here. This factor was derived from the PAPA interview in this case, so slightly different type of assessment. Although broadly, we still did find this hierarchical structure with up to 6 factors at the bottom. And then we wanted to look at whether these early factors were predictive of mental health problems and general functioning during pre-adolescence. What I'm showing here is basically these graphs that show the variance explained in different adolescent psychiatric disorders, where you can see that a model that just includes the P factor explains the majority of the variance in these future outcomes over and above information about covariates, and also whether the children were meeting diagnostic criteria for a psychiatric disorder at the early preschool assessment. But then there are also other adolescent outcomes that were better explained by also considering these specific factors. So you see here for conduct disorders, for example, that the model that consists the P factor explains up to a certain level of variance in conduct disorder, but then this prediction of conduct disorders increases even more when we also consider more specific dimensions. So these were the specific dimensions that I showed you in the previous slide at this lower level here. And a very similar result also we found for measures of functional impairment. So for functional impairment, again, we wanted to consider both the P factor and these specific factors. So to summarize this other part of results, we do find that in these studies from early childhood to early adolescence, we are able to delineate between 5 to 6 dimensions of psychopathology, which are broadly consistent with some of the dimensions identified in HITUP, with the difference that these studies tend to also show these additional factor that captures this neurodevelopmental dimension, which aggregates symptoms of ADHD, but also learning difficulties, autistic traits, which are not very well characterized within the HITUP model. So this is an area of active development that we are working on. And then one implication for these findings is also that we don't necessarily need to, consider the simpler models and more the differentiated models in opposition with one another, but rather they could have could be valid for different purposes. So the P factor might be a good predictor of certain outcomes, but we might want to consider more differentiated factor solutions and more specific dimensions when we want to predict other types of outcomes. I will finish this talk with this recent paper that we worked on that is trying to bring together the perspectives that we have from the research domain criteria and HITUP, with the idea of trying to leverage their respective strengths and hopefully accelerate progress in understanding the mechanisms of psychiatric conditions and informing new diagnostic frameworks. So one thing that I hope that came across from the previous slides is that Adhd and HITUP are coming from two different perspectives to try and essentially improve our progress in understanding and treating psychopathology. Adhd is very much focused on these biobehavioral dimensions and rooted in the brain, but it doesn't have quite as much coverage on more clinical levels and doesn't necessarily emphasize on the importance of psychometric properties of these different instruments. So, for example, there has been research showing that tasks that are recommended within the Adhd matrix might not be that valid or reliable, actually. On the other hand, HITUP very much focuses on more clinical levels, using these different dimensions that capture broader or narrower aspect of psychopathology, but it's really very much focused on this phenotypic level and is agnostic to the mechanisms that maybe underline these different dimensions of psychopathology that are captured in the module. So we set out to find a way to bridge these two frameworks and potentially create an interface between the two. We did this through a literature review, very broadly looking at different elements from the different constructs within Adhd, as well as the different spectra and sub-factors that are included in the HITUP model, trying to identifying studies that were supportive of links between Adhd constructs and these height-up dimensions. This is a higher level view of what our literature search gave us, where we are essentially drawing links between what were the most supported associations within the literature. Important caveats here is that our search was somewhat limited by the fact that not all constructs were investigated as thoroughly as others. So somewhat limited there, and also that height-up is still not providing a full coverage of psychopathology and forms of mental health problems and difficulties in especially for what concerns children and adolescents. So for example, autism is not part of height-up yet, although some of the processes within Adhd are concerned with autism, especially the cognitive and the social processes domain. So these are not here. But what we do have is this map of what are the strongest associations between the Adhd domain and the height-up spectra. And this is a higher level view, but we then also mapped this at the level of specific constructs within each of the height-up of the Adhd domains and specific subfactors and spectra of height-up. So this is an example from of linkages that we identified within the negative valence systems, where a lot of research suggests that height-up subfactors of fear and distress, which essentially capture phobias and anxiety and depressive psychopathology, are showing strong links with a number of subconstructs of Adhd. And this is similar to what we also found for much greater number of links within cognitive systems, but essentially broadly mapping onto thought disorder, disinhibition within the externalizing spectra and internalizing spectrum. So what we think could be interesting about this and potentially useful of using this interface is that researchers that are coming from an Adhd perspective and are interested in certain aspects of the Adhd matrix might be motivated into including some measures that are mapping onto height-up factors, considering this basically guided by the associations that we identified in our review, or potentially wanting to build on some of the more tentative links that we identified in our reviews and that might not be summarizing these high-level figures that we have. So just as a very quick example of what this type of research leveraging this Adhd interface between Adhd and height-up might look like, we conducted this study on this sample of 450 adolescent girls, where we had a very broad coverage of psychopathology, in total 40 scales. And from this, we derived 4 factors that are broadly consistent with the height-up structure: an internalizing factor of anxiety and depression, 1 eating factor, then externalizing and thought disorder dimensions. And what we were interested in was to map these 4 dimensions consistent with height-up with constructs from the Adhd system. So we used measures of cognitive performance as well as EEG measures that are broadly considered markers of positive valence systems, cognitive systems, and negative valence systems. And what we can see here are some of the associations that we found to be significant between these Adhd markers and the dimensions of psychopathology consistent with height-up. One interesting to note here is that we also considered the correlation between these factors, so that the association between the internalizing factor and the greater P300 event-related potential was also taken into account the covariation with other dimensions, so really trying to depict some more specific associations. And beside this correlation, we also found that greater internalizing was associated with reduced marker of positive valence, so a marker of reward sensitivity, and several other associations that are consistent with our literature review. So just essentially giving an example of what conducting this type of research between Adhd and height of marker could look like in terms of wanting to investigate the mechanisms of different psychopathology dimensions. So I'll just get to some general conclusions and future directions before we start our discussion. So I hope that here I managed to convince you that it might be important to consider the study of mental health and neurodevelopmental conditions, moving away from traditional diagnostic categories and of studies that examine one disorder at a time, and that this research could really give us a lot of insights in what could be the shared mechanisms across different conditions, but also what could be better ways for detecting and then treating these different conditions. There is, given the evidence that earlier onsets are associated with the greater degree of comorbidity across the lifespan, I would argue that considering transdiagnostic research and processes is especially important for those of us interested in children and young people. And then finally, for those of us that are already conducting transdiagnostic research, thinking of creative ways of leveraging the strengths of Adhd and HiTOP could potentially be a way forward for accelerate some of the progress that we can make using these different frameworks. So just to finish, there is a lot of work that still needs to be done. Adhd emphasizes, for example, a lot on trying to identify subtypes within a patient population based on potential brain characteristics. And within HiTOP, there is still a lot of room for improvement in characterizing some conditions that are currently not included within the framework as well. So I mentioned, for example, some ongoing efforts into integrating neurodevelopmental difficulties within HiTOP. There is a lot of research that still needs to be done with longitudinal samples. So transdiagnostic research hasn't quite yet managed to extend this sort of life course epidemiology perspective into psychopathology. So definitely there is a lot of research that needs to be done beyond cross-sectional samples, as well as also integrating other types of considerations that relate to the social environment and contextual factors that we know are very important for mental health conditions beyond more biological underpinnings that, for example, the Adhd framework emphasizes especially. And then several ongoing directions within the HiTOP consortium are also for trying to bring some of these transdiagnostic assessments within the clinic. So there is an active development of digital tools for characterizing the different dimensions within HiTOP, but also of developing new scales and questionnaires across different informants that are really designed to map different dimensions of psychopathology that are included in HiTOP. So hopefully lots more work that will be coming out in the next few years. So this is all for me. Thanks very much for listening. And these are some of the key players, my collaborators and mentors over these last few years. So I'm very happy to take any questions, and I look forward to our discussion.
Great, Professor Georgia. I I was delighted listening to you. This awesome, this terrific presentation. Lizzie, would you like to give your comments, to say something?
Yes, thank you so much, Georgia. That was really fascinating. You've been extremely busy over the last couple of years. That was great. I really enjoyed the part at the end where you kind of made that comparison of HiTOP versus RDoC and explained how RDoC comes from things in terms of thinking about the kind of really fine-grained and specific neurobiological and genetic processes or mechanisms that could contribute to a range of conditions, whereas HiTOP is more focused on the clinical and the phenomenology of these conditions. And then your last study that you presented, where you looked at the EEG markers associated with different RDoC and HiTOP constructs. That was really fascinating, amazing. So I was wondering if you had thought about how, so the P factor that kind of comes at the top of HiTOP. So I wondered if you had thought about which kind of RDoC constructs might contribute to that factor, or would it be just all RDoC constructs?
It will probably be all RDoC constructs, in a way that we know that if we think about all the different constructs of RDoC, P is really capturing this severity across all forms of psychopathology. So it's the most general factor that you can get. So in that sense, really, it is it makes total sense to think that it may be associated with dysfunctions within negative valence processes that have to do with fear and loss, positive affectivity with rewards, social processes, cognition, although studies have not really mapped so well across. One thing that we did find in our study is that when you then use the P factor that kind of lumps all these things together, the associations might actually not be as high as you would think. And the reason, let me actually share my screen again. So what we were seeing here is that there are some associations. Let me just give me a second. Is it sharing again?
It's sharing, yeah.
So some associations are positive and some are negative. So when you lump them together within the P factor, you might find that they cancel each other out. So that's where, especially if we want to consider specific aspect of neurobiology, perhaps going into greater granularity with these dimensions at the lower levels of the hierarchy might actually be more useful.
Really
and this is also something that we found in another study. The reference is here. Yes, the first author is Nicole Karcher. She essentially took the dimensions from this model and looked at resting state connectivity within ABCD from the fMRI. And what she found is that the P factor showed quite small associations that were not very robust across different subsets of ABCD. And instead, the strongest associations were with the neurodevelopmental factor, which would be, completely consistent with some of our work on connectivity, some of the work that you have also done with autism and ADHD, showing that disruptions in connectivity are really key in the development of these disorders.
Yes, that's really, really interesting. So then thinking about the kind of clinical pathway using these two systems. So I know they are designed for research into psychiatric conditions, but if we could incorporate them into a clinical pathway. So the P factor, you explained, predicts clinical service use. So perhaps it would be important to refer a child who was presenting with any kind of psychopathology or a measure, if there was a clinical measure of the P factor, to services, and then a more fine-grained analysis would be done.
Yes, so that's very much where some collaborators are moving. So the same researchers that led these studies, they are Lori Warshlav and Joan Luby at WashU and Northwestern. They are very interested in this, like early psychopathology in early childhood, and they are investigating how like an aggregate measure of general psychopathology might be used for these more pragmatic clinical applications. So it's very very possible to want to think that, you know, if you can get an aggregate measure of symptom severity, and you know, it could be done through some fancy modeling like with factor analysis, or it could just be a sum of all symptoms, very similar to what the CBCL total score is, for example. So an index of greater severity is likely to be also identifying those children that might need more support from mental health services and that might have the worst outcomes. So that's definitely something that could be implemented within clinical services without wanting to split psychopathology into different categories. And especially for young children, there might not be so much. First, it's difficult to make a diagnosis very early on in development, except from maybe autism that is diagnosed very early. But also because these different symptoms are very often overlapping and they can change a lot in the first year of life. So maybe really looking at a general indication of severity rather than specific conditions might be more worthwhile here.
Absolutely. And there's also the issue that's being raised a lot just now about how for children, at least, once they receive a diagnosis of one condition, it's quite difficult, at least in some countries, for them to be assessed and receive treatment for another condition. I think a lot of families of autistic kids mentioned that it's really challenging to receive treatment for example, for ADHD or other problems because it's considered under the umbrella of autism. So yeah, that's really important.
And there's something, it's interesting to hear that it's similar in Brazil, but in the UK, that's definitely a big problem. And there are ongoing efforts from, organizations of charities, for example, that are, concerned with neurodiversity and other mental health problems to really try to map on the complexity of these different conditions and how setting children onto certain treatment pathways might actually not be the right way to help them in their total presentation.
Yeah, absolutely. So I also had a question about heterogeneity and how HiTOP kind of deals with heterogeneity in the clinical presentations.
So it's essentially you kind of capture the heterogeneity when you map down onto the more specific components. So this has not been done quite as much because most of the research within HiTOP tends to develop these broader dimensions, but it is also possible to look at more specific dimensions within, for example, within the fear domain, looking at specific dimensions. And so at that point, you end up with a more person-specific characterization across several specific dimensions of psychopathology that may be able to differentiate different people with that would be normally lumped with one single diagnostic categories. So this is one way that HiTOP does that, but it's certainly something that needs to be done a lot more. There isn't quite as much work at this level of granularity as much there as it's probably needed.
Okay, I just have one final kind of comment or question that I wanted to make, because I don't want to leave not enough time for others. So I was thinking, as you were talking about how both HiTop and RDoc approach psychopathology dimensionally, but still all of our clinical trials testing medications or behavioral therapies, they're all based on discrete diagnostic categories. At least I haven't seen any doing a transdiagnostic type approach. And I was thinking perhaps what we really need is for a much bigger push in the clinical trial side of things to start testing treatments like, for example, SSRIs, as you mentioned, for a range of affective disorders and OCD as well, instead of recruiting discrete groups of patients.
Yeah, that's definitely a very good point. And the other side of this is that the patients that are included in RCTs classically are just very rare in a way in the clinical population, because they need to meet very strict criteria for inclusion in the study. They have very few comorbidities. They are also they tend to be like very pure presentations compared to what we see traditionally. And in terms of RCTs for transdiagnostic treatments, I don't know about treatments for younger children, but for internalizing conditions, there is some work that is being developed in this treatment across different emotional problems that is called the Unified Protocol. And there are RCTs that have been comparing this transdiagnostic emotional type of treatment compared to treatment as usual of CBT for depressions, other psychosocial treatments for internalizing problems. And there is evidence that this transdiagnostic approach to treatment, at least for emotional disorders, works better than targeting specific conditions, which makes a lot of sense based on what we know about the comorbidity between anxiety and depression, for example. So
yeah, and the underlying neurobiological mechanisms in terms of what's contributing to the symptoms. That's fascinating. I'll have to read those papers. Okay, so I guess I'll pass over to the others for their comments and questions.
Yes, thanks, Lizzie, for your questions. Professor Uri, Professor Orestes.
Yuri, você quer?
Thank you, Orestes. Thanks a lot, Georgia. I was impressive. I am impressive and how much you can talk about the theory behind all these ideas, but also based on your own data. So that's great, Lizzie. You really find someone very interesting for us to learn and to get some insights about this very complex and difficult topic, I think. So I have two questions, Georgia. When we talk about P factor, for instance, I understand P factor is an artificial statistical measure, right? A label or a concept, right? It's a statistical concept. And in terms of when we think about the future of the HiTop or the new approach, the new nosological approach, more based on empirical data and more valid, I hope. We're looking for validation of our nosologies. How are so I see you as in this group of people that are behind the HiTop. How you guys are thinking in terms of developing new instruments, for instance? So we need a new kit says, a new DALBA, a new SKID to report or to characterize the phenotype. And then based on this phenotype, we really understand what are the components of this P factor or something like that, a common factor. And then translate this in terms of finding predictors for specific phenotypes or higher functional impairment and things like that. So, so this is one question. How are you guys thinking about developing new instruments? And I've seen that there are several instruments already going on, but I want to know if there is something like a skit being organized. Second question.
Yes.
Oh yeah, we're gonna.
I'll respond to this one before I forget. So there is so the P factor. There, it's definitely a very good point that some consider it as a more of a statistical artifact, because really, if the P factor is nothing but the shared variance between internalizing, externalizing thought disorder processes. So it is really much of what is shared across these different dimensions of psychopathology. It might not be the best way to think about how we can move forward in the clinic. And for this reason, actually, several people within HITOP are developing scales that are targeting the specific dimensions. So there is a large work group of people. I am part of the one that is developing scales for ADHD and externalizing symptoms, divided between we have different teams that are developing different scales for different dimensions of HITOP, and then we are bringing them all together in data collection to look at how all these scales hang together in order to be able to develop and release a large HITOP measure that can be used. This is for now mostly based on self-reports. The reason is that most of this research is done with adult populations. And there is such big coverage of HITOP right now that it might be easier to do it through a questionnaire. But there is also a lot of interest in developing these instruments further through some clinical interviews, also using informants. So if we think about research and clinical applications in children, of course, we will want to adapt these scales to parent reports. And the recent progress in developing this scale have been summarized in an issue of the journal assessment. So each of the different teams have published a paper on the development of a scale for internalizing, a scale for externalizing, and so on. So there are some papers that start describing this effort, but there is a measure development takes a lot of time, so it might take a while before we actually have these scales to include into studies.
Okay, great. Second question. I sometimes think, so the whole idea behind the P factor, for instance, that there is a common and shared genetic vulnerability and environmental vulnerability, right? So that general environmental vulnerability, general genetic factor that is associated to this very relevant phenotype. And there is also the concept that the specific individual experience or environmental experience are associated to more specific phenotypes, right? More, okay, this is the general idea. But when we are in our clinical practice and you have a patient, you were talking, I remember a patient I saw yesterday. So this patient came to me. He has anxiety, generalized anxiety disorder, very high. He has Adhd, very important as well. He has drug abuse, alcohol abuse, and marijuana. And he had a depressive episode in the past, not now. So when I was seeing him and I make my skit-like interview, what I used to do, I was impacted by the Adhd. And my aim was, I am going to treat the Adhd first at the beginning. But based on his report, for him, was more important to treat his anxiety. And so I started treating his anxiety and focusing. He also had a benzodiazepinic dependence. So we started working on his benzodiazepinic. I started using SSRIs for this generalized anxiety, and focusing on the benzodiazepinic dependence. Also tapering the benzodiazepines using SSRIs and In his case, it was quetiapine a little bit. And then working hard on helping him to change his behavior approach to alcohol. He stopped using marijuana. So we focused on that for 6 months. And then after 6 months, he's much better on his not using just a small dose of benzodiazepinics. And he's worried, he complained about mind wandering a lot before sleeping at night. And then we decided to focus on his ADHD. Now he's a very well performing bank accountant. So he has a bank. He's very, very productive, very good, doing very well in his job. But now he's worried about his performance because he has a lot of people to perform, and he will have a better performance and improve his working memory. He's now understand what's the working memory and mind wandering and things like that. So we started finally 6 months later with stimulant, something I'd like to start earlier. So in our clinical practice, there are also the subjective patients and how they may understand that there's something behind that can explain several different disorders. But I'm just thinking about this mind wandering here with you in terms of how we have these instruments and how in our clinical practice see the patient individuality, the individual patient.
Could maybe think that if we had a transdiagnostic intervention that could sort of tap into several of these conditions at the time, then we could find a trade-off between wanting to help a given patient that is particularly concerned with some aspects of their psychopathology, but also at the same time target other aspects that might be as impairing, and they could just start being more impairing for them at a later time. So with ADHD, depression, anxiety, one such intervention maybe could be targeting emotional regulation. So that's very much a common mechanism across all these, is associated also with mind wandering and kind of dysregulation in thinking and behavior, also with this functional impairment. So that maybe could be one way in the future to wanting to reconcile what could be an individual's needs at a certain time point, but also wanting to address their full clinical presentation in a bit more of a more global way. But there is certainly a lot to learn still on what could be these transdiagnostic targets and how then to develop treatment strategies that could be impacting as many aspects of psychopathology as possible.
Thanks a lot. Wonderful question. Wonderful response. Thank you.
Thank you for your questions. They were very thought-provoking.
Thank you.
Okay, well, Rodolfo, I wonder if you have any time left for our session, or if are there any questions from the audience as well?
No. There's no question from the audience right now at this moment.
A quick remark. Well, congratulations on your brilliant talk, Georgia. Very nice to hear that. The question I was going to make, I think you explained in your very last slide. So if you perhaps want to reinforce that, if you compare RDoC to high-top approaches, would you say that the first is more biologically oriented, perhaps more integrative, whereas high-top would be more psychopathological based on symptoms?
Yes.
I couldn't find cognition in the high-top description. Is this domain being contemplated in this taxonomy, or it's actually being relinquished to other approaches?
Sorry, could you repeat what you couldn't find? I think that it
cognitive domain in high-top.
Yeah, so this is kind of related to what I was also hinting to when thinking about the majority of neurodevelopmental problems that are not in there yet. So we don't have yet a spectrum that captures autism, learning difficulties, intellectual disabilities, and this is work that we are doing currently in trying to integrate what we are calling a neurodevelopmental spectrum within HiTOP. And then another aspect of cognition that might be that others are interested in is also what thinking about dementias and early cognitive decline, and thinking about potential ways that HiTOP could promote research on the association between mental health problems and cognitive impairments later in life, or like finding associations between early manifestations of cognitive impairments across the lifespan.
Yes, I agree with you that these transdiagnostic approaches are great for neurodevelopmental conditions in child and adolescent psychiatry, but also I would say that it would be very relevant in old age psychiatry as well. And I'm not only talking about dementia, dementia is an array of several syndromes in the same brain. But also, if you consider bipolar disorder in the elderly, it's an array of distinct domains altogether. So I think this would be a pretty good model to be tested as well with these transdiagnosis models.
Definitely. And there is still a lot to understand about bipolar disorder within HiTOP. Right now, it's kind of like put here with these dashed lines because there is still a lot of like work to understand whether it's part of the internalizing spectrum or thought disorder spectrum or both, or whether some manifestations are strongly part of one spectrum or the other. So there is a work group that is specifically trying to map bipolar disorders on HiTOP and trying to create measures as well to be able to integrate that. And the difficult part is that the episodic aspect of bipolar disorder. So the timing dimension is not present in HiTOP right now. We are focusing on dimensions measures more as traits. So elevations of mania that are more limited in time right now might not be well characterized by HiTOP. So there's definitely a lot more work that needs to be done there.
Great. Well, thank you very much. Just one final comment regarding Lizzie's remark on RCTs and clinical trials, and also Euripides about the instruments to depict these pictures. If you look at old age psychiatry and dementia and trials that are being conducted in Alzheimer's disease, we now have, in addition to clinical outcomes, we have also biological outcomes, because we have very good biomarkers for the disease process. We can test whether one given treatment can actually modify these biological markers and assume that something is changing in the natural history of the disease. So I think we really need new parameters to be included in our diagnostic workup, including also not only humoral biomarkers, but also EEG biomarkers and other neuropsychological biomarkers and things like that. Do you agree with that?
Yeah, I agree. And that's maybe where, integrating this transdiagnostic approach across RDoC and HiTOP could really be a very promising avenue, since there is a better understanding of what are the neurobiological mechanisms and some of the biomarkers within these older populations.
Well, thank you.
Thank you. Yeah.
So thank you, Georgia. Thank you, Lizzie. Thank you, Professor Euripides. Thank you, Professor Orestes. I'm sure we learn a lot. I learn a lot, and I'm very eager to read your publications regarding this presentation. So thank you so much.
Thanks very much again for having me. It was such a pleasure and such a stimulating discussion. I really enjoyed it.
And Georgia, thanks a lot. And Lizzie now in depth with us. And she will have to work to bring you here in person.
I would
yes.
I'll work with her.
This pandemic ends at some point, and I can travel to Brazil.
Yes. Thanks so much, Georgia. It was lovely to hear about your work and to see you again.
Yes, thank you. Likewise. Thanks so much
Bye-bye.
again for the invitation.
Bye-bye.
Bye.
Bye.
Bye-bye. Bye-bye, Lizzie. Bye-bye, Georgia.
Ciao.
Thanks, Lizzie.